hired a little over a year ago. My main job was to take care of people having major league strokes. Not the little strokes, the major strokes, the ones that kill you or put you in a nursing home. And it used to be that for patients like that, we couldn't do anything. For anyone that's having a stroke, does anyone know loved one, family member, friend that's had a stroke? So the standard of care is intravenous TPA. Anybody heard of intravenous TPA? You use it for heart blocks. You also use it for brain blocks. Stroke is a nasty surprise. No one sees it coming. Everyone wonders why it's happening to them or their loved one. And it can change you from a normal, everyday person to a nursing home person or a dead person. And what we do is try and prevent that from happening. And what we count on you all for, what is absolutely critical to our success, is time. And if you guys can't get the patient to us as quickly as possible with a pre-notification, we lose time. And for every minute that somebody has an area of their brain that's not getting blood, they're losing billions of brain cells, and they're losing miles of connections between those brain cells. So every minute counts. What we ask you to do is to establish IV access, let us know the last time they were neurologically fine, last known well time, and bring them to us as quickly as you can. Pre-notify us so we have the CT scan waiting. Because when somebody has a neurologic change, we're not sure what's going on. Can anybody tell me what it might be if it's not a stroke? Someone has one-sided weakness or a seizure or can't talk, what might it be?
Glucose issue.
Glucose issue? That would be a normal head CT. What else? Anybody?
Lyme-Bell's palsy.
Lyme-Bell's palsy. Really acute major league problem. Big change in a person. Anybody? From a seizure. A seizure is a big common one, right? Normal head CT usually, but sometimes you have a big brain bleed. Sometimes you have a brain tumor, something like that. And if someone is having those things, it's not a stroke and we can't fix it. Okay? So we're going to talk about what's happening if someone's having an ischemic stroke. That means you're not getting the blood to your brain that you need. All right? We're going to go old school. Ready? Okay. That's me. I get paid by Stanford Hospital, nobody else. I don't work for a company, I just work for a hospital. That's a lot of turtles. I love this picture. We're going to talk about stroke and what you can do to help someone having a stroke. Okay? So there's 3 stroke subtypes. There's the ischemic stroke. That means the brain's blood supply is interrupted. The brain is a very metabolically active organ in most of you. It needs constant oxygen and glucose to do its thing. There's 2 others, really 3 others. There's hemorrhagic stroke, an intracerebral hemorrhage. I'm not going to talk about treating that, although there's new minimally invasive stuff you can do. Someone used to have a big brain hemorrhage. The skull encloses the brain. The skull is like a closed box. And you can't stuff more in your closed box than you already have. So if you have bleeding into the brain, it causes pressure, and it causes someone to have a real bad day really fast. If you can get some of that blood out, it makes a tremendous difference. And we are soon to launch a program where through a tiny hole in the skull, you can evacuate that hemorrhage and really change somebody's life for the better. And then the third is subarachnoid hemorrhage. That's bleeding around the brain in an acute fashion, typically caused by an aneurysm, which is a blister on a blood vessel. And those patients do really badly, really fast. About half those patients die before you can get them to us. And about a third of the patients who arrive with us don't leave the hospital. So it's a very significant disease. We're not going to talk about that today. It's not quite as common as ischemic stroke, though. Okay, so this is where I live. These are the blood vessels to the brain. On the right side is a CT scan with a 3-dimensional surface shaded render, and on the left side is an MRI. And you can see there's the carotid arteries coming off the, oh, maybe you can see, all right, I'm going to jump off the stage. So this is the aortic arch, and you have your carotid arteries right and left. And the internal carotid artery goes up to the brain. And the external carotid artery has all these branches on it. The internal carotid artery goes to the brain. It's a low resistance circulation because it's high volume of blood flow. The external carotid artery goes to the muscles of the face. It's a very high resistance blood flow. So the majority of the blood goes to the brain in most of us, if we're lucky, right? So it keeps us working properly and thinking for our midterms tomorrow. So I'm gonna get you guys out of here as fast as I can. So once the blood vessels get to the brain, you have the internal carotid artery divides. There's the middle cerebral artery and the anterior cerebral artery in the front of the brain. And the middle cerebral artery gets the majority of the blood flow. And most of us who are right-handed, the left side of the brain is the dominant hemisphere. That's who you are. That's where you talk. That's where your memories come from. The right side is the big picture. For those of you that have artistic inclination, the right side gives you that inspiration. It's the big picture. It's the forest. It's not the trees. So these sides of the brain don't necessarily always work so great with one another. And I'll talk about that, how that looks clinically, okay? In the back of the brain, we have a major vessel called the basilar artery that feeds the brain stem. That's the lizard brain. That's the older portion of the brain before the cortex developed. That keeps your heart beating, your lungs pumping. If the basilar artery goes down, you lose consciousness very quickly. On the plus side, the basilar and the brainstem can be out for a long period of time before that area of the brain dies. Much longer than the cortex. The cortex is more metabolically active, unless you're falling asleep from a presentation. Okay, so here's the cortex, right? And the middle cerebral artery is here. This is called the circle of Willis. This is the area underneath the brain, the blood vessels I just talked about, those middle cerebral arteries, those anterior cerebral arteries, the basilar artery, they talk to each other. There's connections, and it creates a circle. So if you can imagine, if you have a blockage here, blood can go around and communicate. And that is a critical anatomic, beautiful thing that the body does for us. If you have a blockage, blood finds another way to get where it needs to go. In addition, there's blood vessels over the surface of the brain. And it goes over and communicates, and we call these collateral blood vessels. If you have a blockage, but you have enough collateral blood vessels, your brain gets enough blood to stay alive. It may not work normally, but it's not going to die fast. And those are the patients we can help. Unfortunately, sometimes patients have these blockages and they don't have the collateral blood flow, and their brain dies very quickly and there's nothing we can do. And sometimes people ask me when I give these talks, so how do I get collaterals? You're either born with them or you're not. But if you take good care of your body, the collaterals you have are going to work better. So we can talk about that if you have questions after. So this is a brain angiogram. Has anyone seen an angiogram before? So an angiogram is a special x-ray. Has anyone seen an x-ray of a broken bone, an arm or a leg? What do you see on the x-ray? Just the bones. And what we're interested in is the blood vessels. So if you're going to see the blood vessels, you need to inject something. We inject something called contrast. It's got iodine in it, and that iodine interacts with the x-ray and blocks it, and lets us see the blood vessels. So maybe you can see this little line here. This is a catheter, much like this catheter. So this catheter is pretty long. Will anyone know why this catheter is so long? Yeah, it's got to get from the leg, the groin, femoral artery, you can feel your pulse, all the way up to here. And the older we get, the longer and more tortuous our blood vessels get, and these need to get longer to get where they need to go. We can pass this around. This is the actual catheter we use to fix strokes. That one's not been used. So, an angiogram is a dynamic test. So what we do, and maybe you can see here, can you kind of make out the skull in this picture? The reason you can see the skull is we first take a picture of the skull. It's called a mask. And the computer subtracts that image from the rest. And then we inject contrast into the arteries, and we keep taking pictures every other second for a few seconds. You ask the patient to hold still. This patient's awake. We say, don't breathe, don't move, don't swallow. You ever take somebody's picture and you ask them to say cheese and don't move? We're doing the same thing. So the first thing you see is the blood in the carotid artery. You can feel it right behind your jaw. That's what we're seeing right here. And you can see like the branches of a tree, it goes from the trunk all the way out, and the branches get smaller and smaller as we go further and further along. Here's that middle cerebral artery and that anterior cerebral artery, and you can almost see them kind of talk to each other over the surface of the brain here. Everybody see that? It's critical. What is in the body between the arteries and the veins? Capillaries. Thank you. So capillaries are happening here. See this gray haze that starts to fill in? That's the capillaries you're seeing. And that's the brain itself getting the blood cells. The capillaries fits a single blood cell at a time. And you're seeing the capillaries in that gray haze. What comes after the capillaries? The veins. I heard veins. So here's the veins of the brain. And then this is the main vein in the neck coming down, the jugular vein. You're seeing that right here. So this is an angiogram. This is a normal patient. If someone's having a stroke and the blood vessel's blocked, you see a hole in the capillary phase. And I'm going to show you that, okay? Does anybody have any questions? This is critical stuff. Yes?
What if someone is allergic to the...
We don't even check. We don't even ask. We just do. If someone's having a big stroke, and I'm going to tell you how we make that diagnosis, they're going to die. And if we don't do something, it doesn't matter if they're allergic. I got a patient in the hospital now who's got probably temporary complete renal failure. We didn't check his kidney function before we did all our testing. Although if we didn't treat him, he would have had a major stroke. He's 90, he would be dead by now. I'll tell more about that story if you want. But it's absolutely ignored. Allergy history, kidney history, we just proceed with the testing. Because if we don't get these vessels open real fast, hours, the patient's opportunity to come back to a relatively normal life is gone, and there's nothing you can do about it. Great question. All right, so this is old, ancient news. Look, from 1995, were most of you, any of you born in 1995? On the floor. I was born. Okay. So before 1995, when someone was having a stroke, there was nothing you could do but hold their hand and make them comfortable and try and control their blood pressure and their blood sugar and console their family, and you just watched it happen. And there was nothing you could do. In 1995, it was shown that if you give the clot-busting drug TPA, you've heard of TPA, that dissolves blood clots, patients did better. The downside of TPA is it creates hemorrhage. About 6% of patients who get TPA get a hemorrhage. About 10% of patients with an untreated stroke have a hemorrhage. So patients who are selected properly, who get TPA, do better than patients who don't get TPA. Does that make sense? Said that fast. You bleed and you do worse if you don't get TPA. Now the challenge is, the first thing we do is that head CT. Because if the head CT looks really bad, your risk of hemorrhage from TPA goes way up. And we don't give it. And we don't do a thrombectomy. And I'm going to show you an example of a really bad looking brain. If the brain looks too bad, if too much time has gone by, and you don't have collaterals, you can't fix the brain. Okay? So there's a happy guy who's getting TPA because the patient has a blood clot, and you give this large volume dose systemically of TPA. And you can't give it to anybody, everybody, because someone who's had a history of bleeding, someone who's had major surgery, someone who's had a brain bleed or has a known brain tumor, or who's on blood thinning medicines, you can't give TPA. So if you can't give TPA, you stand by and watch them have their stroke, and they call me. I don't care if someone's on blood thinners. I don't care if they have a brain tumor. I don't care if they've had major surgery. I can still do what's called a thrombectomy. I can use mechanical devices to get the blood clot out. So it's a big difference. The important thing for you to know, I'm going to keep repeating this, the faster you get them to the hospital, the faster they get a head CT. If they're a candidate for TPA, they get it. And if the TPA is not going to work, we go to thrombectomy. Is that clear? Because that's all critical stuff. Okay. All right. I'm gonna skip this. All right, so I'm gonna talk about a large vessel occlusion. I showed you all those branches. So as the tree goes from the trunk to the branches, the stuff out in the periphery is tiny, tiny stuff. A millimeter vessel, a 2 millimeter vessel. TPA works great for that stuff. When you get to that circle I showed you, the MCA or the ACA or the basilar artery, those are more like 2 or 3 millimeter vessels. TPA doesn't work for those. Those strokes are devastating. They're called large vessel occlusions. They're not the most common, but when they happen, those are the ones most likely to put someone in a nursing home or kill them, okay? So since 2018, when I was hired at Stanford Hospital, we've seen 20 patients with large vessel occlusions that we were able to treat. 2 of them, you were all kind enough to deliver to us, okay? Half the patients we've seen have gone home. And half the patients you brought to us, we were able to send home. One of the gentlemen I remember very, very well. He unfortunately died. But the thing to remember is, if you don't treat someone with a large vessel occlusion, they're gonna die. All of them. So half doing well is a win. It's very sad for the family. And it's unfortunate, I see his wife all the time, and she's very appreciative and thankful for all you did and we did, even though we couldn't save her husband. But the gentleman who we were able to save, I speak to his wife too, and they're very appreciative and they thank you all very much. And we might hear a little more about that in a little while. Okay, so this is a graph for those of you having midterms tomorrow. And it's a log scale. And what I want to show you is, on this axis is the probability of opening a blood vessel. And on this axis is the length of the blockage of the blood vessel. So as the length of the blockage of the blood vessel goes from 1 millimeter to 2 millimeters to 3 millimeters, what's happening to the probability of the opening of the vessel? It goes to the toilet. Once you hit 7 or 8 millimeters of blockage, TPA is not going to work. And this was a seminal paper that really changed the field. When I was training, if we had someone with a blockage in their blood vessel, we used to give them TPA and we'd watch and we'd wait. And I already told you, every minute that goes by, you're losing millions and billions of cells in the head and miles of fibers in the head. So watching and waiting is stupid if it's not going to work. And what we look for is those big vessel occlusions, and we don't wait. We give TPA in the ER, we get the angio room ready, and while it's dripping into the patient, we race them over to the angio suite. And what's the worst thing that could happen? We do the angiogram and the vessel's open. And that happened about 6-7 months ago. A 65-year-old woman who had acute onset of half their body weak, hemiparesis and aphasia, difficulty talking. And we gave her TPA in the ER. She had a large vessel occlusion. We got her on the table in the angio suite. You don't put anyone to sleep unless they can't protect their airway. And she was able to do that. We did the angio, we got the catheter up to her neck, and when I shot the vessel, it was open. And that's honestly the best case scenario, because she did fine. She had some cardiac issues which created her embolus. So once those were under control, about 3 days later, a 63, 64-year-old woman, she went home. Instead of dying from a hemispheric infarct, she went home and she's okay. So if someone is eligible for TPA, they get it. That's a critical piece. Everybody cool with that? Okay, so if you have a blockage in your blood vessel and you're exhibiting stroke symptoms, so does anybody have any idea what cortical stroke symptoms look like? Anybody heard of the FAST scale? Tell me the FAST scale. Face, okay, so if you have a facial droop, if you have arm weakness, if you're not talking properly, that's signs of a cortical stroke, okay? The reason we can still save somebody who has a cortical stroke is that cortex, that really metabolically active area of brain, is not getting enough blood to work properly, but it's getting enough blood to stay alive because of those helping collateral blood vessels. The problem is, if there's a blockage here, there's always a complete stroke right next to it. That's called the core. But there's this whole area nearby, it's called the penumbra. And the penumbra is the area of the brain that's not getting enough blood to work properly, but it's getting enough blood to stay alive. The core is not getting enough blood to stay alive. This is a key concept. So the core is not getting enough blood to stay alive. The penumbra is not getting enough blood to function. You guys are good. I'm glad you're awake. All right. So when we first started treating these strokes, we had these devices called the coil retriever. It was originally developed when we were treating other problems in the brain. If things flew off and caused problems, we would use this thing to go snare it and pull it out of the head. It wasn't designed to fix strokes. It was a first generation device. It caused a lot of problems and we couldn't help people with it. Then a second generation device had a big suction catheter. The large bore blue catheter that's going around is the newest generation of that device. And I have, let's see, I might have one. Here. Here's another generation of that device. It's very soft. If you poke it into your hand, and if it was wet, you'd find that it's extremely slippery. So those are two very important characteristics. It's very easy to slide through the blood vessels, and it doesn't cause problems when it bangs into stuff. So this aspiration device has a big opening. You hook it to a suction pump, and you move it all the way into the brain next to the blood clot, and then this little poker would come out, and you'd stick it out into the blood clot over and over again. And you have a question?
Yeah, how do you navigate it from the femoral artery all the way up to the
Very careful. So we're using live x-rays, and these things are visible under live x-rays, and it's my job to steer them through all the vessels and look at what I'm doing. And one of the challenges, the patients are moving around and it becomes very difficult. You have to know where you're going. And I'm going to show you an example of what that looks like. So you're poking this thing into the blood clot over and over again. What do you think happens if you're poking something into the brain over and over again? You're making holes. So these patients sometimes would have bleeds, and sometimes we couldn't get the clots out. So this second generation device was pretty good, better than this, but not as good as the third generation device. So the third generation device is called a stent retriever. Let me have your help here. Hold on to that. Hold very tight. Anyone heard of a stent before?
Yeah.
In what context? Heart. So if someone has a clogged heart vessel, we place a stent, which is basically a spring that holds the vessel open, and we leave it there. This is a stent retriever. Hold tight. I'm going to pull. What do you think's happening? It's not coming loose. Here it is. You can't see it because it's tiny. So I'm going to pass it around. Feel how soft it is when you see it. It's very, very softer than your hair. It's made of this stuff called nitinol, and it's meant to be squished into this plastic tube that allows me to deliver it into the tiny blood vessels of the brain without damaging it. Unfortunately, sometimes it still does, and we run into trouble, but most of the time it's pretty good. So feel how soft this is. The back end is real pointy, so don't poke anybody. So pass that around.
So can that one aspirate as well?
No, we need the suction catheter that's being passed around to go. That stent retriever goes through the suction catheter. And the suction catheter is hooked up to a vacuum pump that pulls negative 20 atmospheres, which is enough to hold a bowling ball. So we simultaneously suck the clot while we're pulling it with the stent retriever, and most of the time that gets the clot out. It doesn't work all the time, but it does work most of the time. And I'm going to show you an example of that. Okay, so when someone comes to the hospital and you roll them into CT because they're not behaving normally, they have a facial droop, an arm weakness, their speech is wrong, the first thing we do is a head CT. What we want to see is this. This is a normal side. What we don't want to see is this. This is a completed infarct. We cannot fix this. Once the brain is dead, it's dead. This is what we're looking for. We do more than just a regular head CT. We do something called CT angiography. I showed you a catheter angiogram, those pictures that went all the way across. This is a CT scan with an injection into the vein, the same contrast. We time it. The blood goes from the vein to the heart, through the lungs, back to the heart, and into the arteries. And then we take our pictures real fast in a few seconds, and we see the blood vessels. And we look for the occluded blood vessel, that MCA blockage, or that basilar blockage. And then we keep going. That's not enough. We look for those helping blood vessels, those collateral flows. We do another injection, and instead of a real fast 2-second scan, the patient's head is in the scanner, and we take pictures just like the angiogram every other second for about 20 seconds. And we watch the contrast flow through the brain, and we get perfusion data. Okay, so these pictures are real pretty and colorful, but there's a lot of them. There are about 600 of these, about 1,500 of these, and about 600 of these. So if it's noon and you get 3,000 images and you're going to go through them and you're already working, it's not a big deal. But at 2 in the morning, it takes a little while for someone to call me, wake me up, log in, find the patient, open the images, look at the images, didn't work, got to download, got to reboot. It takes a lot of time. It could take like 20 minutes or a half an hour 20 years ago to figure this out. But we use artificial intelligence. The images are pushed to the cloud, and artificial intelligence software does an analysis of the perfusion, and it sends me an email before the patient leaves the table. And the CAT scan saves like 20 minutes. So time is brain, so that's a huge savings. And it allows us to choose who we can treat and who we can't real fast. And it's extremely valuable. This is what the artificial intelligence shows us. These are 3 pairs of images from 3 separate patients. They all have a blocked blood vessel on this side of the head. So if you compare the blood vessels over here, blood vessels over here, would you say they're about the same? They're about the same, okay? So this patient has a completed stroke, a small one, and the computer codes the perfusion data with a red dot. That's dead brain. The green area is the penumbra. What's the penumbra? Wait, I didn't hear anything you said. It's getting enough blood to stay alive, but not enough to. All right. So the green is the penumbra. When the penumbra matches the core, there's nothing we can do. This is dead brain, and there's no brain at risk. If you compare the vessels over here, there's an occlusion on this side. If you compare these two, would you say there's a little bit less in the circle over here? Yeah. Yeah. So the reason for that is there's not enough blood flow getting to this side of the brain. So there's a core. Everybody has a core. But look at this penumbra. This is the patient we're looking for. If we see this, it's hair on fire. Everybody runs. And we get this patient to angio as quickly as possible and try and get the clot out. Unfortunately, sometimes we see this. If you compare the vessels over here to the vessels over here, it's awful. It's awful. It's a desert. There's nothing here. This patient either has that completed infarct that I showed you or horrible collaterals. Yes?
In the middle image,
Yes?
how much time would you say you have to get the cloud out before it all?
You know, it's highly variable. This is a simplification. We get more data than this. There's a lot of things I can go into it with you after. We get some other stuff, and everybody's different. So some people, you have days, and I'm going to show you an example of that. And some people, you have hours, and we can get to them quickly enough, and their brain's dead before we even get them to the hospital. So everybody's different. You know, we're all basically the same, but we have subtle differences between all of us, amongst all of us. And those collaterals, if they're not quite right, and you have a bad clot pattern, it doesn't matter and your brain's dead before you get to the door. But we can talk more about that if you want. Okay. So this is the first patient we saw. This was December of 2018. This is the first patient I saw at Stanford. And of course, in 15 years of doing this, it was like nothing I had ever seen before. So this is a lady, I have never had to actually convince somebody to have a thrombectomy. Meaning I could talk to them, and she was yelling at me, and I said, please, and she said, why am I here? So the lady had like a 3-day story of waking up, not feeling quite right, and they would put her to sleep. Have you heard that story before? When someone's not feeling quite right, the family just puts them to bed, and they wake up dead. You probably, unfortunately, said, this lady's so lucky. So this happened Friday, Saturday, Sunday, and Monday. For whatever reason, they finally decided to bring her to the ED. And we did the CT scans, and this is the perfusion. It's blue instead of green, but this is her penumbra. So this is her dominant hemisphere. It's the in-charge hemisphere. It's the one that makes her who she is. And it was, some moments she was normal, and some moments she was symptomatic. She had aphasia. She had mild hemiparesis. Her speech was weird. And it's because her left hemisphere, right in the motor area, the memory area, the speech area, wasn't getting enough blood to function normally, but it was getting enough blood to stay alive. Why is that? She had anatomic variation. The yellow arrow is pointing to this little nubbin here. Can you see this little tiny nubbin here? This is her middle cerebral artery. She had a duplicated middle cerebral artery. Like, you're never going to see that. So this lady, her duplicated vessel was occluded, and the main branch was open. So it was keeping this area alive. Thank God she got to us, because if she waited much longer, if that other collateral goes down, she loses the blue part, and she becomes hemiparetic, aphasic, can't talk, can't move. She's 60 years old, and she's in a nursing home. So finally we convinced her to do thrombectomy, and we got a 2-centimeter clot out of her duplicated MCA. 3 days later, she goes home and she's fine. That's the best case scenario. This is another story. This is a gentleman from Stanford, not the hospital, but the town. He's 50 years old. It's a Saturday morning. I remember it well. My daughter had just had oral surgery, and I was home. My wife was visiting her parents in Florida. I'm home alone at 6 in the morning, and I get a call. And I'm like, oh no, I gotta leave. So this gentleman's having breakfast with his family, and he's got 2 young children, and he's been married for 20 years, and his wife looks at him funny, and he's like, what's the matter? So he thinks he's saying, and he's talking gobbledygook. And not only that, his left side of his body is not moving quite right. He's dropping pancakes and stuff, and he thinks he's fine. But she knows he's really got a problem, and she's arguing with him about coming to the hospital, getting fixed. You're having a stroke, you gotta go. He's like, he thinks he's saying I'm fine, but he's not making any sense at all. So he has a right-sided brain problem. So if you're a right-handed person, which side of the brain's in charge? Left. So the left, the dominant, the U brain is fine. The right side of the brain, the servant side of the brain, is having a bad day. Does the left side care? No. So the left side thinks everything's great. He had no idea he was going to die. She finally talks him into coming to the hospital. We do the CT scan. There's an occlusion on the right side of the brain. Look at these colors. Red is really, really bad. You were asking about, like, some people die before they hit the door. This means how long it takes for blood to get to the right side of the brain compared to the left. Red means it's taking 10 seconds or more. And it can be as slow as 4 is green, and it goes from 4 all the way to 10. 10 seconds is forever in brain physiology. These are what we call rapid converters. A patient like this hits the door and you don't act quickly, the brain dies before you blink. And fortunately, the team worked really fast. We got him to angio, and we turned, this is his MCA, which is gone. So here's the carotid, here's the anterior cerebral artery, you can kind of see the eye here. It's cut off, it's not supposed to look like that. We opened it up, it looks like this, okay? And he was amazing, I'll never forget. I haven't seen this many times when I've heard about it. So the first thing I do when I see a patient in the ER is I talk to them. He couldn't talk to me, he was talking gibberish, and he couldn't move his left side. On the table, I asked patients how they're doing because they're awake. And he couldn't tell me, he was talking gibberish, and he certainly couldn't move his left side. The right side was strong, and he was fighting me. I'm going in the right groin, and he's like hitting me down here, and I'm trying to, because he's awake, and he doesn't like what's going on, and he certainly thinks he's fine. So I had like a tech holding his hand, and I'm like holding him off, and we finally got the vessel open, and I'll show you what that looked like. But I'll never forget, I said, you know, Mr. Patient, how you doing? And in the beginning, he's like, and then we got the vessel open. Mr. Patient, how you doing? He said, oh, I'm fine. And it was like mind-blowing, really. It's exactly how it's supposed to happen. And this is his angio. So if you could see, there's that cutoff, right? Here's the internal carotid artery, and here's that occlusion, and this whole area, wow, that's really crappy, I'm sorry. But as you can see what you need to see. And you can also see, the spaghetti is meant to show you the thickness of the catheter. I think I have one. Yeah, here's the pre-perfusion, here's the microcatheter that's the size of spaghetti. You pop it against your hand, it's very, very soft, because it's going out into the brain. And if it's not really soft, it causes damage. You see how he shakes his head?
Yeah.
So right here is the cavernous sinus behind the eye. It's very sensitive. When you're dragging stuff through there, it hurts. But you can see over here, it's like a loop, right? So here's the suction catheter, here's the microcatheter, and here's the microwire going out into the occluded vessel. Here's the suction catheter. I'm going to show you more of that. Here's the stent triever. You see these three dots? Those are dots that you can see on X-ray. You asked me how I figure out where everything's going. The dots show you. So here's one of those things, 5 times normal size. You're welcome to squish it in your hand because it's made of that nitinol metal that springs back. 5 times is like an elephant stent triever, not a human stent triever. So it's got those radiopaque markers on it. So that when you pull it down, you're going to see them go like this again because it hurts. There he goes. And right about then, we got the blood flow going back, and when he told us he was fine. There he is. So that's to compare the image on the left to the image on the right. He doesn't have a hole in his capillary phase anymore. Here's my big fat thumb, and the 2 centimeter clot that came out. And he was great. He went home 3 days later. 50-year-old guy, 2 kids your age, and he would have died for sure. Okay, so that's stroke. There's a buffalo. That's the grand teacher. Anybody have any questions? Yes, sir.
When you're pulling the catheter back through, does it perforate the artery when you're pulling
You
the
can. You absolutely. You know, about 1/3 of the patients do great. About 2/3 of the patients don't. And in 1/3 of the patients, we can't get the clot out. Another third, we damage the vessel, they bleed, and they die on the table. And it's happened, and it's miserable. And explaining that to someone's family is the worst part about what I do, and it happens too often. But it can absolutely happen.
Each one of those catheters that you showed us, how much time elapsed independently for the development of each one?
You know, in the development?
Well, yeah, I mean, obviously, you said this one wasn't so
Oh,
good.
it's
and
been
the one-
about, okay, so the coil treatment, the first
Yeah.
one, was like late 90s, early 2000s.
Okay.
And then the penumbra aspiration with the poker was like the 2010s. And keep in mind that the FDA is very slow with approval of stuff for good reason, and a lot of stuff gets used in Europe before it comes to the States. The stent retrievers were used in Europe about the 2010s, and they didn't come to the States until the early 2010s. And then they were widely used around 15, 16, and when the clinical trials that proved that this stuff was worth doing, and now there's 17 variations available to us. So, you know, it took about 20 years. Yes?
So 50 and 60 seems pretty young. Did either of those patients have predisposing factors or histories? Did I miss, do you say that? I'm just
So
curious.
it's funny you should ask. So the first lady, when I went to the ER to meet her, I met her and I met her husband as well. And it's funny because I went to shake the husband's hand. He got up from his chair and he walked over to me. You can imagine what happened to him before. And you know, you may all know firemen. What do firemen smell like? Smoke. This guy smelled like a fireman. He smoked like a chimney, had a prior stroke, and I couldn't believe that they waited 3 days to come to the hospital. So she had untreated high blood pressure, smoked like a chimney, had absolutely out of control cholesterol. She was a train wreck, and she was a disaster waiting to happen. I should say that she left the hospital fine, but she doesn't like following up with doctors, even though she has this problem. So she's likely to return. Any other, yes?
Just piggybacking from what Margot was asking about, like the LVO type of infarcts. What's on the horizon? What's exciting research-wise? What can't you wait to get your hands on that might come into your?
So I would say the most significant wish for all of us that is treating stroke patients is to extend the amount of time the brain will stay alive. There has been very little success in encouraging the brain to live through a period of time without the blood supply it needs. So cooling, you've heard of people that get cooled, has been helpful, but the brain tends not to do so great in cooling. So we're looking for neuroprotective agents. There's a whole biochemical cascade that happens when the brain isn't getting the blood it needs and it starts to self-destruct, essentially. So we have yet to find the magic drug that will increase the amount of time that the neurons stay alive. That's the wish. That's the next thing we're looking for. And tons of people are looking for it.
And the constellar pathology, are they predominantly fatty or what are they predominantly?
You know, it's funny, when, in my former career when I was in the Bronx, I diagnosed a tumor in the lady's heart. The tumor broke off and embolized to the brain. Most of the time it's blood clots. They're either white clots or red clots. And you know, the white clots usually come from the legs and the red clots come from the heart. So, you know, we get some clue as to whether it's from a heart defect or a blood clot in the leg. Question?
When you are inserting this through the femoral artery, how do you like control which way it
So
goes?
is there a wire through there? Or is it just the
I
catheter?
think it's just the catheter.
So if there is, can I have that one, please? Thank you. So you can see that this thing is kind of curved, and on the end of the wire is also a curve. So when you're outside the body and this is wet, it's very slippery, and you can actually turn it. And you're looking under x-rays and you can navigate this thing. And some people's vessels are horrendously tortuous and it's very difficult. But you're basically just kind of following the road. You're doing injections of that medicine to see the vessels and you're following the road up. And if you're lucky, you get there.
So then if there's a patient who has like really windy vessels, is there ever cases where like your catheter is too short?
I've had that happen and it's just such a bummer. So you just start over, you get something bigger. So this is just a sample of the tools we use. This is not the only one. There's a whole wall full of catheters and wires that we use. And you don't always use the femoral artery. You can come from the radial artery. And if someone has horrible disease, sometimes the aorta is occluded. Sometimes the femoral arteries are occluded. Sometimes the radial vessels are unavailable. You can do a direct carotid stick if you have to.
I'm wondering why you wouldn't just do that.
It's dangerous. And so if you get a hemorrhage in the neck, you can occlude the airway and the patient will die quickly. If you could dissect the carotid, it's not, certainly not the best of choice. The femoral and radial much safer.
Just since time is such a critical issue, is there an issue more with TPAs in this? I know as far as when you can start the procedure, or is it
Yes.
just time
So
of brain?
TPA originally was limited to 3 hours of safety, and that was based on a study from 1995. It's called NINDS, and we only tested it out to 3 hours, and anyone after 3 hours had too high a risk of hemorrhage. CT technology has gotten much better since then, and we've gotten better at selecting patients. Right now, you can give TPA up to 4.5 hours if the head CT looks good, and that's gonna probably extend because we're gonna use perfusion for TPA as well as thrombectomy. Right now, we're not using perfusion to select TPA patients. So you can expect the window, if you will, for TPA to continue to grow. But as far as I'm concerned, there's no window for thrombectomy. If the brain looks good and the physiology is good, that lady was 3 or 4 days out. Yes?
How many times have you had to do this?
This year, 20. In my former life, it was much, much busier. I've probably done 100 or 200 of them. And, you know, another couple hundred treatments for hemorrhages as well. And another couple thousand diagnostic angiographs. Other questions?
Are you the only person, only doctor who does thrombectomies at Stanford?
I am the only neurointerventionalist that will do a thrombectomy at Stanford. So when I go on vacation, we get people that fly in to come cover the service.
Wow.
But you're on call 7 days a week.
I am on call right now. Yes.
Does Norwalk Hospital do the same?
You know, I've heard that they do. I'm not sure that they don't. And the same is true. The same is true of Greenwich. I'm pretty sure Greenwich is ahead of Norwalk.
Why do you attribute the numbers dropping so significantly throughout your career?
Oh, well, I was working in the Bronx before, so there's 1.5 million people, and they're really sick, and there was a ton of strokes and bleeds and everything. And there's maybe 100,000 people in Stanford, 120. So, you know, big. And I had 5 partners. It was like a totally different scenario. Other questions? So I have lots of other stuff, but it's about 20 after 8, so maybe this is a good time to let you go study. And I totally appreciate your attention.